Yes.
Yeah, okay. It's recording now. If people are not happy for them to be in the recording, please switch off your camera. Otherwise, we are already recording. I'm not going to take any time from the speakers. Thank you, Paul, Stacey, and Douglas for joining us today. We wanted to show the benefits of system dynamics also across boundaries, so something that is not NHS focused, but brings together the NHS and the care sector. That's why we have a dedicated session for this presentation today. I'm not going to do any other introduction, actually. I will just hand over to Paul, and then the three of you will manage your timings there. I will be checking the chat box for everyone. Feel free to post to drop your questions in there. And we keep in an eye in the chat box. Paul, Douglas, and Stacey, when you feel there is a natural break in there, let me know, and we check what we have in the chat box. Thank you.
Perfect. I'll kick off. I feel we should start with a quick introduction, actually, just to say who we are. So I'm Paul Johnston. I'm an associate working with West Midlands ADASS, covering policy, performance, and data, but also supporting the region's commissioning network, and specifically with the focus on the market shaping duty that local authorities have, market shaping and market sustainability duties that local authorities have. Stacey, do you want to introduce yourself, and then Douglas, and then I'll come back to talk about the introduction.
Yeah, I'm Stacey Croft. I'm an analytics manager at the strategy unit. For those that don't know about the strategy unit, it's an NHS-based consultancy. We apply clear thinking and analysis to improve decision making and implementation in health and care. My role with the strategy unit is providing analytical support to major health and care change programs. So we help our clients understand the impact of proposed changes to services to make better decisions. My particular expertise is in developing discrete event simulation models, but recently I've been getting more involved with system dynamics and working with Douglas. I'm particularly drawn to participative modelling approaches, drawing on different perspectives to produce models that are understood by their users, so they can explore multiple possibilities. Douglas, do you want to say hello?
Hello, I'm Douglas McKelvie. I had a previous career in social work and in social work education. For the last 20 years, I've been working mostly in modelling and simulation in the health and social care sectors, using mostly system dynamics. And I'm from the kind of often overlooked part of the West Midlands, so speaking to you from Edinburgh, but seem to spend most of my virtual life in the West Midlands these days, and it's a great place to be. So I'll pass back to Paul now.
Brilliant. Thanks for that, Stacey and Douglas. And I should say that I'm also in the Northumberland region of the West Midlands. So anyway, if I can start by, I guess, reminding people that councils are under a statutory duty to promote the efficient and effective operation of a market for services to meet care and support needs. And I think that requires us to develop a really good understanding of factors like demand, capacity, workforce, service design, service performance, and so on. And of course, with an eye on the future operation of the care market, we need to understand the effects of planned and unplanned changes within and across those factors if we are to maintain a sustainable care market that provides high quality, efficient and effective services. So in initiating this work, we wanted something that would allow us to see the potential impact of changes in those thematic areas on a service that we recognise as being challenged, but which is critical to the future operation of the care market. Next slide, Douglas, please. So for most people, living in their home and community is a fundamental right and expectation, really. But for some of the most vulnerable people in society, this can only be enjoyed with the support of high quality domiciliary care. And domiciliary care, or dom care, is an essential component of the health and social care system, supporting many thousands of individuals to lead happy and independent lives in their own homes. But as I said earlier, or alluded to earlier, the service is under immense pressure. We know that demand and expectations are rising. Recruitment and retention of of staff is increasingly difficult, and of course financial constraints are never far away. If domiciliary care isn't provided, then the effects are felt not just by those who need the service, but also by a wide range of aligned health and care services. And of course, we know the impact on hospital beds becoming blocked and care homes being overrun, and not always with demand from people who would, or for whom it's appropriate actually for them to have their care delivered in a care home. So whilst accurate data about people who fund their own care isn't available, ONS data suggests that there's around 320,000 people aged 65 and over, 90% of whom live at home, who require help with domestic and self-care tasks, and a further 30,000 younger adults who require help with personal care. West Midlands councils spend £770 million per annum on community-based care and support, out of a gross total expenditure of around £2 billion. And we estimate that we're supporting 57,000 people to receive care, to receive support to live independendly, and that's out of a total of about 87,000 people who receive local authority funded care packages. I mentioned self-funders earlier. It's also worth remembering that self-funded care is a significant factor, and we estimate that local authorities fund around about 70% of all domiciliary care services that are provided. So it's a significant additional aspect that needs to be taken into account when we look to understand the care market. The adult social care workforce data that's collected by Skills for Care shows that there are around 50,000 care worker jobs in domiciliary care services within the West Midlands. And there's an average staff vacancy rate of around 10% and staff turnover of 35%. There's a large proportion, 87% of the workforce, that's female and an average age of 43 years. Average pay in the sector is only marginally above the national living wage. And these are all factors that, add complexity, I think, to the management and understanding of the workforce. We also know that anecdotally, staff are leaving the sector for better paid jobs elsewhere, some in logistics, but a large number that actually go into the NHS. And these factors are combining to drive up both competition and cost for staff. And we know that the market for agency staff is particularly active and is significantly driving costs in the sector much higher. So health and social care policy promotes home first as the preferred option to enable people to live healthy, active and independent lives. But the provision of domiciliary care is identified by social care commissioners as the #1 priority and challenge. And keeping pace with the shared ambition of health and social care systems is therefore a significant threat and a significant challenge for us. The move towards more integrated approaches to health and care provide an opportunity for us to look at things differently and to take a whole system approach to strategic planning. And we're delighted that through the Association of Directors of Adult Social Care in West Midlands, that our social care colleagues in the region have now got the opportunity to work with the strategy unit to explore the challenges facing domiciliary care and the opportunities that exist to transform and improve the service. And I'm going to hand over now to Stacey.
Thanks, Paul. Next slide, Douglas. Thanks. Okay, so you can see from that domiciliary care failure is untenable. How can we secure and stabilise and enhance this critical service? Well, solutions have been proposed, including increasing pay for care staff, improving training, career prospects, increased use of reablement services, use of quality or outcome-based payments for contracting, additional support for informal carers, etc., etc. But how do we weigh up these different options to test whether they might work, estimate their costs and impacts, and ultimately make the case for sustainable change? This is where this project comes in. The aims are to increase understanding of the demand drivers for domiciliary care in order to identify future system implications and to inform local and perhaps even national decision making in the medium term. Next slide, please, Douglas. Thanks. So we combined Douglas's experience of system dynamics modelling with subject expertise of social care and health colleagues. We were inspired very much by a project Douglas did in Northern Ireland, looking at policy implications of the cost of care there. And what we did in the West Midlands was we brought together a mixed group of stakeholders from local authorities, social care commissioning, data and performance analysts, service managers, for reablement, for brokerage, and some of the provider organisations like West Midlands Care Association and Structured Partners in Care. We started by focusing on what the problem is, and then we used the stock and flow mapping of system dynamics as a way of clarifying how those things work and where the problems might be. We progressed the work through a steering group, through a modelling group, and through individual meetings for specific aspects of the modelling. So we met with various people along the way, representatives of Age UK, the Institute of Public Care, for example, people from Skills for Care, particularly around the workforce issues. And we built the structure of the model that you're going to see through this group learning inquiry, where the stakeholders collaborated to explore how the system works, its main constraints, the dynamic impacts, current challenges and shortages, as well as the future possibilities. Next slide, please, Douglas. Okay, so the model that we've built aims to explore the various challenges facing social care in the provision of domiciliary care over the medium term, sort of 10 to 20 years time, and it will enable the investigation of the changing demand and shape of domiciliary care. It includes impacts not just from an ageing population, but also from changes in choice of a care setting, workforce factors, the impacts of reablement services, the increasing complexity of domiciliary care in place of residential options, and we also have been getting into the funding side of things. Questions we might seek the model to answer are highly interconnected, so they comprise different balances of care, shifting the thresholds at which people may require residential or nursing care, for example, or exploring impacts of different amounts of home care that might be needed. The model's intended to aid West Midlands ADASS and the local authorities in the region to look at their social care services and investigate alternative scenarios, identify the extent of shortages or imbalances in the workforce, and help assess the implications of different policies to tackle these. It's expected to assist in demonstrating to the NHS the assistance that domiciliary care and reablement services can provide in reducing demand for bed occupancy in hospitals and the avoidance of more costly placements in residential and nursing homes. It takes, as Paul mentioned, a whole systems perspective, looking at social care costs and the impact on related costs to the NHS. And we think this will help integrated care system partners to better understand these dynamics and therefore to consider a shared response for how these are addressed. I think I'm going to hand over to Douglas now to actually give you a good look at the model itself.
Thanks, Stacey, and thank you to Vanessa for inviting us to be part of this event. Just acknowledge the amazing contribution that Vanessa's made over the last few years in terms of raising awareness of and adoption of system dynamic modelling, which is truly impressive. So just given that this today is a bit of an introduction to system dynamics for some, so we're not going to give you our introduction to system dynamics other than point you in the direction of a couple of pieces of for reference. This one is free, so if you look up the School for Social Care Research, NIHR, then I think this is more than 10 years old now, but it's got some useful reference material about how system dynamics can be used in health and social care. Unfortunately, this one is not free, but it is more up to date, and it does have quite a range of examples of pieces of modelling in the healthcare sector. So I'm going to move out of PowerPoint. So just, I think I'll take my screen down while I'm doing that. Just spare you the pain of looking at my navigation. So here we go. And we're back, hopefully.
Yeah, you are sharing your Stella.
Okay. So this is a description of the structure of our model using the language of stocks and flows. This is not actually the model, the great thing about system dynamics is that in order to build the model, you have to construct a diagram. As you've already seen this morning, although it's this afternoon now, so as you've already seen today, these diagrams can become quite complicated. And so what we also sometimes do is that having constructed our model, we then construct a simplified diagram, but using the same language to explain what's in the model. So this is our sort of explanation of the model, but it's the actual model has more detail than this. Domiciliary care, I'll assume that most people know what it is roughly. There is a demand for domiciliary care, and therefore there's a stock of people who need domiciliary care, but they have not yet been referred to us. And it's important to know more about them, how many there are, and what their level of need is. Next stage in the journey is that there's a service pathway. So people are referred for care, and they may have to wait if care is not immediately available, and then they move on to be service users. And after a period which could be between a year and several years, people then stop using a care package, either because they've recovered, more likely because they've moved on to a higher level of need, perhaps in a care home, or indeed through mortality. If people don't get the care they need in time, then they can end up in hospital. And so there's a group of people who are in hospital and need domiciliary care. And these are a subset of delayed discharges, if you like. So you'll see one or two references in the presentation to delayed discharges. And when I'm referring to them, I'm referring only to the people who are in hospital because they need a care package. So not people who are waiting for other things, and not people who are in the assessment process. And so there's a route, therefore, into using domiciliary care from hospital. The other possible route is that people are admitted to hospital while they're still waiting for a care package. So we don't want people to be waiting for the care package, because if people are looked after better, they're less likely to need to go to hospital in the first place. And there's also a flow of people who are service users, and they go in and out of hospital, and sometimes they can resume using their care package without a delay. Sometimes they have to wait to be reassessed. So there's a service pathway. And there's a capacity. And with domiciliary care, we're not talking about beds or buildings, we're talking about staff. So the service capacity for domiciliary care is staff, and therefore this is a stock of staff. We need to recruit staff, and we hope that staff don't leave, although, as Paul has already explained, turnover in the sector is quite high. For home care, we're interested in the labour market. It's different from many jobs in health and social care because there's no pre-entry qualification requirement, so you don't spend several years training to be a care worker. So quite often, if we're doing workforce modelling, we're interested in how many students go on to courses and how long it takes. But for the domiciliary care workforce, it's a much more immediate thing. There is a labour market. There are other jobs out there. There are other employers who will attract staff who might otherwise work in the care sector. And so some of the ways in which we can influence that would be particularly the rates of pay. So before I do that, notice that we've got a number here for the desired number of staff. and we'll connect that elsewhere in the diagram shortly. So we've got a desired number of staff, we've got a number of staff, and that means we've got vacancies, and that means that we need to recruit people. We may influence recruitment depending on the rate of pay, and we may also influence turnover depending on the rate of pay. So depending on what pay is on offer and other conditions, it's not just about pay, it could be about training opportunities or management supervision. We can influence, so with better conditions, turnover can be reduced, and with better conditions, we're more likely to attract recruits. There's a description of the service, things like how many hours of care do people need for how long, fairly basic things like that. And from that, we can derive a requirement for how many staff we need. And that gives us the number of staff that we actually, so you can see a feedback loop there between the service specification, which says that this is the number of staff we need. The number of staff we need determines how many vacancies we have. If we're successful in recruiting people, that gives us a number of staff. And then the number of staff we have completes the loop and gives us our home care capacity, which is the number of people we can look after. And that connects back into the inflows from the waiting list. So we've got staff, that gives us a capacity. That means that we are able to provide access to the service. There's another thing that's really quite important in all this. So far we've got several different types of people. We've got people in need who we don't know. We've got people who've been referred to us and our service users, and we've got people who work for us, and that's what our stocks and flows represent. The other stock that's quite interesting is money. So Stacey mentioned that we try to take a whole systems perspective, and taking a whole systems perspective does not mean that you model absolutely everything that you could possibly model, but it does mean that you have to take a number of things into account. So in the costs in our model, we're obviously interested in the cost of care, which is largely derived from how many staff we've got, but also how many managers, what the training costs are, pensions, national insurance, all these things. There's another cost in here, though, which is the cost of delayed discharges, which is what does it cost to have people in hospital simply because there isn't sufficient domiciliary care. And so based on the occupied bed day cost, then we can figure out how much we're spending on delayed discharges for that reason. And if you put these together, then you get a whole system cost, which you'll see in our diagram. Now, in the model, there's much more detail than this. So, for example, if you look at the demand side, you can see that this is a kind of typical description of people gradually increasing independence as they get older. So as we enter the last number of years of our lives, most people living independently. Some people die while they're still managing to live independently. Other people have an increased dependence and need care at home. Some people may die while they're still at that stage in their lives. Other people no longer managing that need a care home. And so that's a kind of population description of the population. And we're particularly interested in this group of people in the middle. Looking at official data sources, we look particularly at the English Longitudinal Study of Aging, ELSA, and that describes aging in a slightly different way. People moving from independent to having a low, medium, or high level of need, and we've extended high into high and very high, where high corresponds roughly to a period when you need domiciliary care, very high where you would need residential care, and probably medium would be where you have in fact it says here on this panel. So low dependency means people who need help with bathing or showering, so perhaps they need a visit once a week, or more than that, but not every day. Medium dependency, people who need help dressing or preparing food. Clearly that people need help every day at that point. And then other people who need help using the toilet or chair fast or bed fast, problems with continence. And people in the high dependency group obviously would need a visit more than once every day. So that's roughly how it works. If we look at the workforce, for example, then you can see that we've got care workers that give us our service capacity. We've got vacancies. We've got people who are in the process of being recruited, and we've got potential people who might work for us who come from the labour market. We've got rates of pay and other conditions which give a degree of attractiveness to working in the sector. The rate of pay at the 25th percentile seems to be particularly significant according to Skills for Care analysis. That drives the turnover rate and also the attractiveness piece. And also the more attractive the rate of pay is, the less time it takes to recruit. So you can see the different connections around the diagram that will influence how the model behaves. And there's also this bit here of churn between jobs. So a lot of the turnover that Paul mentioned is actually moving from one care job to another. So there's quite a lot of the movement is actually within the sector rather than leaving the sector. Let's just mention data because it has cropped up. So you can see in a model like this, we're going to look at a number of data sources where, and this is the examples of the kind of data that we've consulted. There's no single data set that would enable you to populate the model. So for the demand part of the model, we're interested in things like the English longitudinal study of aging would help, the joint strategic needs assessments done by local authorities. In the service specification part, we're interested in data from local authority commissioners and the brokerage parts of the local authority, who are the people who match service users with care packages. On the workforce side, that's quite difficult because domiciliary care is provided by a large number of small companies. And the best source of labour market data is the database of Skills for Care. But there's also data from commissioners and providers and data about the labour market as a whole. On the service user side, then we're interested in how people flow through services in the local authority here, but also what the flows are in the NHS, particularly people in hospital who need care. And then on the costing side, there's ADASS and the Local Government Association have done a lot of work on detailed costs of care, so that's useful. For the cost of delayed discharge, we're using an occupied bed day cost. And we're also interested in the cost of staff. So basically, this is almost using the language of calculus, but one of the interesting things about system dynamics is that it's interested in integration. It brings things together. It brings evidence of different types together to form a big picture. So what we're going to do now is just go back, remind you of that diagram. I'm going to move very quickly. I think we're going to try and be finished by about 20 to 1. So we've got about 10 minutes left, so that there will be time for discussion questions. I'm just going to show you some screenshots now of the model running and the kind of experiments it can do. And that's going to require me to stop sharing my screen for a second while I move back to PowerPoint. So just if you can bear with me while I do that. Okay. Is that the right screen? You can see my screen.
Yeah, we can see the
Yes,
high
we
level
do.
You
view.
can see the screen. Excellent. Right. So that's the kind of diagram. Most of the models that you've seen today, when you try to engage with the model, you need some kind of interface to enable you to do that, because there's a lot in these models and there's only certain inputs and certain outputs that are of interest at any given time. So this is a kind of dashboard view of the model. And this is a sort of base run of the model. So this is what tells us what's going on inside our model. On the top left, that is the top row there is a representation of people who are referred to or using our services. So the graphs represent a 10-year period, and you can see that the number of people waiting it goes up and comes down again, but we often have people waiting. This area at the bottom is people waiting in hospital, and the part on the top, people waiting at home. So that light red color represents people who are delayed in hospital at any given time. This is sized for one local authority at the moment, but it's neither of the local authorities who we mentioned earlier, actual data. So just to be clear about that. The first stage in getting domiciliary care is to use a reablement service often, and you can see its occupancy goes up and down. You can see also that the dark area in here represents people who are using reablement, who are ready to move on to a domiciliary care package, but there isn't enough capacity for them yet. So there's people waiting here to move to there. There's people waiting here to move to here. So that's the number of domiciliary care service users. There's a grey area above this representing spare capacity, but you can see that we don't actually have any spare capacity. Down here, we've got the workforce, and that's the number of staff we have. The blue area and the area above is the number of vacancies. So the total is how many people we want to employ. The bottom area is how many people we actually do employ. This graph here is quite important, called provider margin, which, as we said, that this service is provided by a whole range of small companies, and in order to remain in business, they need to make some kind of a margin. So that scale is from 0% to 20%, or minus. I should say minus 20%. The minus seems to have fallen off, so I'll need to figure that one out. You can see that their margin is therefore somewhere about 2.5%. We have a lot of people waiting. Therefore, our costs, if you in this final screen, the green area is the cost of providing domiciliary care. The amber area is the cost of providing reablement, and that piece on top is the cost of all these delayed discharges. So this is maybe an exaggerated picture of what can go wrong, but let's try and come up with some solutions in a second. On the right-hand side of the screen here, there's a range of variables that we can keep track of, and we could add some more to these, and these will enable us to do some kind of sensitivity analysis as we run the model under different conditions. So the big difference between the graphs on the left and the graphs on the right are the graphs on the left of mostly, apart from the provider margin one, got more than one variable on them, and they show you the current run of the model. The graphs on the right show the history of different model runs, and each graph only has one line. And then at the bottom of the screen, there's various inputs. So clearly we've not got enough care. We've got people waiting. So the first thing we might try is to commission more care. So if I click on commissioning commissioning, that's the one. Somehow I managed to go forward 2 steps. So by drawing on a line on that graph, I've commissioned more care, but all that's happened is I've just created more vacancies. We've not actually got any more care. And so nothing much has changed in the model. So let's try doing something about pay here. So now we've put the rate of pay, we've increased the hourly rate of pay. And you can see that what's happened here is that we've managed to fill our vacancies in the workforce. That means that we have got enough capacity in our domiciliary care sector. We've now got spare capacity and increasing number of users. Our reablement is less under pressure because we've nobody much waiting in reablement to move on to a care package, and we've nobody waiting in hospital. But if you look at the overall costs, they've actually come down because we're no longer paying for the delayed discharge piece. So if you look at this graph here of the total costs, that you see that was our original scenario, the top one, and our second scenario. That's actually our first and second scenario when we increased the service we were commissioning, but we didn't change the rate of pay, and now we're paying people. So as we've increased the rate of pay, so our costs have kind of come down, or certainly not increased. There's an elephant in the room here, though, because what has also happened is that our provider margin has come right down to below 0%. And the reason for that is that we're now asking providers to pay their staff much more, but we're not giving them any more money. So the final thing that we should do, if I just move on, is increase the hourly rate. Now, please don't quote these figures because this is still a work in progress and it still requires some data. But if I move on to, so at a contract price, previous contract price, which you didn't see, was about £22 per hour. If local authority was prepared to pay £26 per hour, then the provider margin would move from being this line, which is unsustainable, to the dark line at the top. So now we've got nobody waiting, a bit of spare capacity, no vacancies, sustainable providers, and we're still paying around about not much more than we were paying to begin with, and without all the additional costs of delayed discharges. So that's just a brief glimpse at how the model behaves. So I said earlier that the model is, you think of the model as an integrator. It brings together data from local authorities about service pathways, capacities, flow, duration, commissioning, detailed costs, data about the population in need, and data about the workforce and labour market. The modelling work has taken place against the backdrop of a social care crisis, which is on our news every week. Certainly this morning on the Today programme, there was an interview with a senior doctor who was describing exactly what I just described, of how when you've not got enough care, then people, you've got delayed discharges in hospital, and if you have delayed discharges as a consequence of a lack of care, then you have people who can't come out of accident and emergency, and you have queuing ambulances and all the other things. And the solution to the ambulance queues might well be to pay staff more in the care sector. Do you need a model to prove this? Well, that's an interesting question. Maybe you don't, and then I'm out of a job. But if we're paying about £25 per hour for domiciliary care, and the average service received is no more than 2 hours per day, do we really need a model to show that keeping people in hospital at upwards of £400 per day makes no economic sense? Quite apart from the impact on personal well-being, because the last thing you want when you're old and beginning to move into dementia is to be in hospital. And if there's anything worse than being in hospital, it's being in hospital for no good reason. So that's what this model is about. And I think we've possibly finished, but before we take questions, I don't know whether Stacey or Paul want to add any closing comments.
I think the only thing I would sort of add at this stage is to say, you know, that this is very much at the final end of the development stage, and you know, we haven't been able to use this model in sort of practices yet. We're on the point of launching that and doing that. But it's been really powerful actually in terms of illustrating some of the interaction between these different factors. And I think we need to recognise as well that there are certain things that are within our gift within social care to influence. So we would dearly love to be able to pass on the type of increase that Douglas has mentioned and identified through the model, and make sure that that gets into the hands of people who are providing care, because we think that's where there's going to be the biggest impact. But actually, in terms of the funding that comes into local government, that is fixed. It's not, that's not inflated in any way to take into account this type of model. And therefore, we think that there's value in having this as an evidence tool to support the sector's argument for a bigger slice of government funding in order to make sure that systems operate in an efficient and effective manner. And reinforcing that message is really important, but it's also something that, at a local level acts as something of a frustration, because we can see through this model, we can see the impact of actually making more money available to care workers, the type of impact that would potentially have. But we're frustrated because we're not able to do that through the constraints that we're working with. Anyway, questions. We've seen quite a few questions in the chat. I don't know whether you want to pick through some of those, Vanessa.
Yeah, I think, Paul, I'm going to start the questions in my head. I'm thinking in the system dynamics learning process, which is actually starting on the stakeholder engagement part. So I will start with Joseph's question, which is about how you work with the various stakeholders to agree on the level of details, and it's about that boundary settings. That is the first question I would like you to answer. And the second question is about the rurality factor that is mentioned by Laurie, because I think that's key in terms of setting those boundaries again and saying what is in, what is out of the modelling process. If we could start with those two questions first.
Yeah. And what we've tried to do, I'll let Douglas speak to the difficulty of the challenge, but what we've tried to do is to use published and nationally available data as far as we possibly can to feed the model, but always recognizing that that there is a requirement for local engagement and a fair amount actually of local data to inform the sort of the detailed operation of the model. And Shropshire and Coventry have I think approached the task in a slightly different way, I think it's fair to say. The speed through which partners engage with the model obviously has an impact on the manner in which it's produced and can be brought into use. As a sort of a member organisation, what ADASS is trying to do is to encourage authorities in the region to participate in this and to see the value in contributing our data, because ultimately we see this as a means through which we can access additional levels of funding in order to meet this particular challenge. But that in itself is a significant issue for us. Douglas, I don't know whether you want to say anything about the specific task.
Yeah, I think there's been 2 or 3 challenges in this project that make it a bit different from some other projects. So the first one is that the main client, if you like, is that this is an initiative that's been taken jointly by the strategy unit working with the Association of Directors of Adult Social Services, and from that we've then enlisted a couple of local authorities who would be interested in participating. But I think that can contrast with some of the projects that have been described earlier today, where there's a clear demand from specific hospital trusts or integrated care systems for a model, and therefore sometimes the conversation's been slightly different in terms of engaging the interest of the stakeholders in the project, and maintaining consistent attendance at meetings. So the normal way that we would work would be to get a large group of people in a room and use something called group model building, which is well referenced, and iteratively work, probably meet every 3 or 4 weeks over a period of about 5 or 6 months. Typically, you can meet more regularly than that, but that it's often something like that. And so there's 2 challenges. One is actually keeping the group together, but the second one is the challenge of doing all this online using Teams rather than having people in the room. But so in the early stages of the meetings, we tend to be getting people to work almost from a blank screen and building various diagrams of how people flow through the system. At that point, we went into a surprising amount of detail about the assessment process and about some of the other pathways, discharge pathways, particularly discharge to assess type pathways. And then there was also the importance of reablement as a point. So after a few iterations of that, we arrived at the structure where we weren't going to look at the other pathways because many of them ended in residential care rather than domiciliary care, and that the focus became very definitely the interaction between the hospital, reablement, and domiciliary care. Meanwhile, we had on the side of that contact with and really good engagement with Skills for Care, looking at the workforce. And we had some academic involvement. I would have liked more, to be honest, because I do think that we need some help with doing some of the population piece, particularly. One of Stacey's colleagues has done some work to support us on that. Particularly, I mentioned the looking at the ELSA data, for example. And actually what proves to be fascinating is that if you've got data from different sources, so if you have data from local authorities and you have data from Skills for Care and you have data from published studies like ELSA, when you try to join them together, you find that the number of people being looked after by local authorities is clearly only a subset of the people who might need care. So how do we do the calculations about who actually needs care? And who needs to be reached? And obviously there are alternatives. People buy care privately. People are looked after by informal carers. There's the role of technology. There's a whole lot of things. And then on the workforce side, the same thing applies. That the workforce reported in the Skills for Care data seems to be much bigger than the workforce you would need to provide the amount of care that local authorities are commissioning. And partly that's also because people are buying care privately. It's also because of the way that Skills for Care code things. It's also because, for example, that people who live, so agencies, if you were quite clear that the best boundary for this model is to do it by local authority, if you're looking at social care. Now, clearly, when we get into integrated care systems, we might be looking at more than one local authority. But so we're doing local authority, but there's not necessarily a correspondence between the agencies that provide domiciliary care and particular local authorities. So the process that Peter Lacey referred to this morning of triangulation, of getting evidence from different sources and then trying to make sense of how it fits together, that's one of the main contributions that this kind of modelling can make, actually. I feel that I've spoken a bit too much about this issue, and I saw some comments flying across my screen, but I couldn't read them. So
I'll just pick up Laurie's particular question that Vanessa wanted us to look at. So there is within the model, we've modelled rurality and travel times quite briefly, but there is in there like a contact time in our workforce calculations, converting the workforce to capacity. And so if there is greater travel times, then you would adjust that contact time with clients through that. And we also, there is in there the costs for travel times as well in there. So it is in there, but we haven't modelled them in detail as such. And Douglas and Paul mentioned many of the points I would have done around the how much level of detail to agree with the stakeholders. But yeah, because it was an iterative approach, as Douglas said, we did go down some blind alleys, put too much detail in, and then take a step back. So
yeah, but can I also say on the rurality part, because I think we have got that quite well covered actually, because one of the model inputs which corresponds to the detailed costings work that ADASS and the Local Government Association have done is the travel distance travelled per visit. It's about 1 mile, and so we can easily in the model change that 1 mile to 2 miles or 10 miles or whatever it would be. So in an urban area, then the distance is going to be relatively short. In a rural area, it's going to be much longer. And in fact, I'm not going to demonstrate this right now, but the overall costing behavior of the model is very sensitive to the miles traveled per visit. So that does actually have quite an impact. So if anyone's interested in finding out more about that, then please send us an email and I'll happily give you more detail in that. So the model is capable of tackling these differences. Yeah,
it's at the level of the average for providers, rather than us modelling individual providers. Then that would be a separate exercise. But we are at the moment, I think 2 of them might actually be on this call, training some of the analysts from the local authority themselves on how to do system dynamics modelling. So should they want to then go down the route in future of modelling individual providers and helping providers in that way, then that might be something they might investigate in the future.
Thank you, everyone. There were a couple of questions in the chat box around cost. And I wanted to check with Bruce and Sarah whether you feel that those questions have been answered with the presentation, because you asked them at an early stage during the presentation. Bruce, how you feel about it? Is that lower total cost has been, or you have any comments?
I am so excited by this. It's so super briefly, I've been in the NHS for 15 years and I do improvement and quality. You know, worked in hospitals for a number of years and now NHS England. But before that, I was in the car industry for 18 years. So all of that process flow and quality and lowest cost system thinking, you know, is where I come from. And obviously you're doing this with adult social care. And that's where it started from. But clearly, massive benefit for hospital acute flow and therefore everything else to do with hospitals. So you're, you know, I'm sure, you know, you worked this out already. I'm sure you will have huge supporters in this for all the clinical teams in hospitals right the way through the whole system. So how do you kind of, you know, take that and get with the local politicians as well to get the answers into, you know, the Department of Health, because they don't get, you know, they don't get this kind of stuff. They think that they don't see a flow problem in a system. They see an ambulance handover thing and think, let's throw money at ambulance handover. It's going to be wasted compared to throwing less money to make the situation better for everybody. Yeah,
that's actually a point I wanted to make, that at the moment we only take into account the cost of the delayed discharges. What we don't take into account some of those more indirect costs that build up, you know, further into the hospital around the ambulances queuing at A&E and the impact that has. So that currently isn't in there.
Yeah,
it is something we'd like to do in future, but it's not in the scope of this model.
Huge harm risk of harm that is happening and has gone up. I've seen someone recently in the last couple of months make an attempt to work out excess deaths to do with acute care pathway delays. You know.
Thank you. Sarah, I wanted to check about your question as well, because it was also related to cost and how that increase in the pay per hour was transferred to the actual workers in there, but also what was the margin for the provider. Do you feel that that was covered in the presentation, or you want Douglas or Stacey and Paul to?
No, I think that was covered. Thank you.
Yeah, we're getting to the end of this breakout room session. Is there anything else that I haven't covered? From Robert, perhaps there's a new questions in there. Yeah, it's about environmental cost and mileage and distance. Are you there already, or is part of the journey what you're trying to implement in your model?
Yeah, no, we haven't built in any environmental costs, have we, Douglas?
No, I mean, if by that is meant the amount of miles travelled, then we could certainly look at that. But I don't know what. Well, I suppose that I mean, actually, well, here's an interesting thing. Actually, I will. So somebody please remind me, because I will forget. We could do a calculation of the total miles travelled by care workers in particular scenarios of the model. I'm not sure what the implications would be. So the implications might be that therefore if care providers actually issued their carers with electric cars, or I'm not being frivolous. I'm just saying that if the service consists of people moving around a local authority, providing care to people in their own homes, it must involve travel, and you know, I used to work in an urban social work office where you could walk around and see most of your clients, and the home care workers were just the same. They just walked about. None of them, as far as I noticed, had cars, but that wasn't Shropshire. So I think that if we value looking after people in their own homes, then if there is an environmental cost, it's probably something that might be offset by some other cost somewhere else, I guess. Yeah, interesting though.
Thank you, everyone. For Joseph's question, which is about Stella software, if someone provides you a link that's called Exchange interface, you can have a look at their model when they post it online. You don't need a software installed in your machine. But if you want to develop the model further, have a look at all the equations, you will need to pay for a license. And we are going to discuss and cover part of that in the community of practice session later in the afternoon. It's 1 o'clock. We are supposed to be back in the main room at 1:30. So we are having a 30 minutes break now. I wanted to say first, thank you to the three of you for the presentation. It was really good. And you are making evident what lots of us believe should be evident across the health and social care sector, but you are proving that and you are providing the evidence that is required to build that case, to make the case in there. Thank you so much for that. And for everyone, apologies, Robert, we won't have time for your question now. Hopefully later, I will see all of you back in the main room in half an hour. I will post the link in here, but otherwise, if you leave this room and you still have open that main session, it's just to resume that one. Otherwise, use the link I'm going to put in the chat box. Thank you, everyone.
Thank you, Vanessa.
Thank you for your kind words as well, Douglas.
Thanks for coming, everyone.
Thank you.
Thank you.
Thanks. Bye-bye.